published widely on that. And he's awarded the Oliver Kroner Prize, which is kind of the Nobel Prize in neurosurgery, for the work that he's done in cerebral metabolism in acute brain injury. He's published over 700 papers. So I think you did manage to publish a few papers and keep your job, isn't it? He's been the lead applicant in over £20 million of grants, including MRC, NIHR, Brain and Spine Foundation, and he's published in New England Journal of Medicine, Lancet, and Brain. He's also been author of Oxford Textbook of Neurological Surgery. And he is now the treasurer, he's been treasurer of the International Neurotrauma Society and also the meeting secretary for the SBNS. So, the list goes on, and I'm delighted that you could give us the time tonight and talk about neuromonitoring in traumatic brain injury. Thanks very much.
Great. Thank you. No worries. Okay, thank you, Mohsen, for the very kind introduction. I've had several visits to Ireland, and I think the first memorable one was 1995 for the SBNS in Dublin, which was actually my first SBNS, and that was a very memorable occasion. But this is a special visit to Dublin because I'm now Irish. So my grandfather was at Trinity, and my grandmother's from Belfast, and I applied about 18 months ago for Irish citizenship, which is 9 certificates of births, deaths, and marriages of all my grandparents and parents, and it took 18 months, but last month I got a certificate through saying that I'm officially Irish, so I'm very proud and emotional to share that. So it's a special occasion. If you let me off that, Kieran, I'll chair a session in Cork, all right? So the topic of my talk is actually quite niche. So Mohsen asked me to give quite a specific talk on neuromonitoring for traumatic brain injury. So I'm going to focus on a very specific aspect of neurotrauma, that is management on the intensive care unit, and specifically some of the monitoring that is used both clinically and in research to monitor the injured brain. So as you know, we've made many advances in the management of these patients, but there are several unanswered questions. The cause of traumatic brain injury, and I'm sure you're seeing the same here, is changing. So this is some work that we did through the Global Neurotrauma Network, looking at the etiology of traumatic brain injury across the world. That's good. Yeah, minimize that. Perfect. Okay, perfect. So what we're seeing now is a change in the etiology of this condition, and in parts of Europe and North America, falls in the elderly are now a predominant cause for traumatic brain injury. Now, historically, traumatic brain injury and head injury for neurosurgeons has meant this. It's been an interest in taking out blood clots. This is a historic picture of an operating theatre from the Wellcome collection. But I think what we're learning to recognise is that head injury is much more than taking out hematomas. It is the concept of managing patients with contusional injury, with diffuse injury on an intensive care unit. And that is the subject of the talk, is how we can actually improve the monitoring of these patients. The problem, as you know, is that there is a direct impact to the head that results in brain swelling. There may be secondary insults, hypoxia and hypotension. The brain is confined by a tight box, the skull, and the consequence of swelling is an increase in intracranial pressure. The consequence of an increase in intracranial pressure is a reduction in perfusion pressure, a reduction in blood flow, and cerebral hypoxia, which results in energy failure and further swelling. And this vicious cycle culminates in poor outcome for the patient. What do we mean by monitoring? Well, there are now a number of technologies that exist so we can actually get a handle on some of these pathophysiological derangements. And as you're aware, the gold standard and the most common monitor used now is the intracranial pressure sensor. But there are other ways we can look at brain function. We can measure blood flow through transcranial Doppler, thermodilution techniques. We can measure cerebral oxygenation, and we can measure energy failure. And I guess what we're trying to do is that these techniques are fantastic for writing papers, but actually, are they useful in terms of clinical practice? And as I said, really, ICP, I think, is the only one of these that has really percolated into the clinical domain, but there is increasing interest, particularly in brain tissue oxygen and possibly microdialysis. So this is the standard monitoring setup in Cambridge now. So all the patients with traumatic brain injury, poor grade patients with subarachnoid hemorrhage, have this bolt inserted. This has a triple lumen, so it measures as well as the intracranial pressure, brain tissue oxygen through a brain tissue oxygen sensor, and microdialysis brain chemistry through a microdialysis probe. So what I'm going to do is really focus on the various research and clinical utilities of these monitors. So intracranial pressure is the gold standard. We've been able to define limits for this, what is normal, around 10, abnormal greater than 20, severely abnormal greater than 40. And we know that a sustained increase in intracranial pressure leads to poor outcome for the patient. And there's been many studies now, this is some of our earlier work from Cambridge, showing that a raised intracranial pressure is associated with a poor outcome, particularly in terms of mortality. The brain's an amazing organ. It has this tremendous ability to maintain its cerebral blood flow across a very wide range of blood pressures, anything from a mean of 50 to 160. And this is the classic autoregulation curve of Lassen, where you can see this long plateau of a constant cerebral blood flow across a very wide range of blood pressures. The problem following brain injury is that this relationship of autoregulation is often impaired, and when there is a fall in the blood pressure, the brain is not protected. That is then associated with a fall in cerebral blood flow. So hypotension is then associated with ischemia. When the brain is autoregulating, it's like driving an automatic car. Whatever you do, the brain will sort itself out. But following injury, we have to carefully control the blood pressure to preserve blood flow. And using that, you can define what we call these pressure reactivity relationship, where you get different patterns of the relationship between blood pressure and intracranial pressure. The so-called passive response, where as the arterial blood pressure goes up, the intracranial pressure goes up, and other instances where an increase in intracranial pressure, an increase in the blood pressure can result in a reduction in the intracranial pressure. This is the so-called active response. This is a state of autoregulation. This is dysautoregulation. And we can now put that together with an ICP sensor in terms of this bedside monitoring software that's been developed by my colleagues in brain physics, Peter Chmielewski and Marek Krosniker, which look at the relationship of the blood pressure, the ICP, the CPP, so the difference between the ICP and the blood pressure, and define this index of PRX, which is the status of autoregulation. And then at the bottom is what we call the traffic lights, where you can see in this patient there are periods where the brain is autoregulating in green and dysautoregulating in red. And this is highly relevant because it can change the way we manage the patient. If the patient is autoregulating and the pressure is high in ICP terms, by augmenting the blood pressure with inotropes can actually lead to a reduction in intracranial pressure. If the patient is not autoregulating and you try and increase in the blood pressure, you will lead to a further increase in intracranial pressure. But this is one of the ways where these technology is now percolated through to our clinical practice. So if you go beyond pressure and look at the oxygenation, there are three ways by which you can measure the oxygen status of the brain at the bedside. The first of these that was introduced into clinical practice was jugular venous bulb oximetry. You put a bulb, measures the jugular venous oxygen saturation in the venous effluent from the brain. I'm not going to talk more about this. It was great in terms of research and experimental terms, but it really didn't translate into long-standing clinical practice. Near-infrared spectroscopy, again, this has the advantage, it's non-invasive, you're putting these octrodes on the scalp, but this again is very much a research technique. But this technique of direct parenchymal tissue PO2 sensor is probably now the second monitor beyond ICP that is moving into clinical practice. It's about the same diameter as an ICP probe, it's a Clark electrode, and it measures the amount of oxygen within the tissue. It does tend to relate to blood pressure. This is some of the work we did in our earlier studies showing how the brain tissue oxygen is preserved up to an arterial blood pressure of around 80, but once you drip below that, the brain tissue oxygen falls. And it is a very sensitive sensor, so we did at some stage monitor our aneurysms and temporary clipping. You could place the tissue PO2 probe within the parent distribution of an arterial clipping, temporary clipping, and you can see that the profound effect on brain tissue oxygen shown there in blue. But it is quite complex. We're not measuring the oxygen in the blood vessel, in the capillary. We're actually measuring the oxygen in the tissue surrounding the cells. And what we are finding in a number of these patients that despite a good oxygen supply on the arterial side, the oxygen may not be getting to where it's needed. So there is what we see, a diffusion barrier or microvascular ischemia in many of these patients. This is the normal situation of perfusion. This is simple hypoperfusion, macrovascular ischemia, where there is cerebral ischemia universally or diffusely. But in certain parts of the brain, we're seeing this collapse of the microvasculature and a perfusion utilization mismatch. The consequence is that although there is good oxygen delivery, it may not be reaching where it is needed. This brain tissue oxygen, we are seeing a good relationship with the cerebral perfusion pressure. We are now beginning to establish a threshold for what is an abnormal brain tissue oxygen, a bit like the ICP threshold, and that is around 10 to 15 millimeters of mercury. But it's really changes in the values are probably more important than the absolute numbers. And also with these probes, you have to look very carefully at where the probe is placed, because if it's in a contusional area, you will see different oxygen levels clearly compared to normal brain on CT. So probe placement is important. One of the big steps forward for brain tissue oxygen monitoring was the BOOST-2 trial. So this was a phase 2 randomized trial where patients were randomized to an ICP monitor alone in one arm versus an ICP monitor plus a brain tissue oxygen monitor in the other. And if you do add this monitor, you will detect quite prolonged periods of time of brain tissue hypoxia by adding the brain tissue oxygen monitor. That can then be treated. The question is whether that actually improves outcome for the patient. And that has now led on to 2 larger phase 3 trials of brain tissue oxygen monitoring. One led out of the US, the BOOST-3 trial, and one led out of Australia, Bonanza. So these are ongoing, and I think will provide useful information as to the clinical utility of this monitor. How do we use brain tissue oxygen monitoring? Well, there's been various consensus statements. These are some of the recommendations. So this came out of the Neurocritical Care Society in the US, recommending brain tissue oxygen monitoring in patients with or at risk of cerebral ischemia and or hypoxia. It did at the time talk about jugular venous bulb, but as I said, I think that has now really disappeared. While there is persistently low brain tissue oxygen, this does appear to be now a strong predictor of mortality and favourable outcome. So this society has recommended the addition of this monitor alongside ICP. Also suggesting that it can help with the titration of medical and surgical therapies. And we found a particular useful brain tissue oxygen monitoring as an indicator of how safe is hyperventilation. We know that hyperventilation lowers ICP, it causes vasoconstriction, it reduces cerebral blood volume, pressure will be reduced. But there is a concern you may vasoconstrict to the point of provoking ischemia. By using a brain tissue oxygen monitor, there is now good evidence that it can help you titrate hyperventilation. The third probe of interest is the microdialysis probe. This is, I think, further away from clinical utility, more in the research domain at the moment, but does provide some quite interesting information. What is it? It's another catheter, like an oxygen and pressure catheter. It is placed directly into the tissue. It is perfused with fluid from a pump, which passes down the catheter. The tip of the catheter is where dialysis occurs, so molecules diffuse across into the fluid in the catheter, which is then collected in these vials that are changed hourly. What you can measure with microdialysis is the glucose delivery to the brain, how that is metabolized by glycolysis to pyruvate, where it is converted to acetate, and that is where the citric acid cycle is then generated and ATP is produced. You get very little ATP out of glycolysis, as you recall. Most ATP comes out of the TCA cycle. The problem following brain injury is these derangements, hypoxia or mitochondrial dysfunction, and then pyruvate is preferentially metabolized to lactate, and this lactate-pyruvate ratio can therefore be used as a marker of abnormal metabolism. There's been a lot of interest in using microdialysis clinically. Does brain chemistry monitored by it relate to clinical outcome? Can brain chemistry be improved with therapy? Does it provide more information than other monitors, ICP and brain tissue oxygen? Can it detect secondary deterioration? What should we monitor, injured or non-injured brain? And can we actually incorporate this into the management of patients on an individual intention to treat basis? There's been quite a few studies now showing that derangements in brain chemistry measured through microdialysis catheters relate to poor outcome, particularly this lactate-pyruvate ratio, also glutamate as a marker of excitotoxicity, and glycerol in terms of cell membrane breakdown. So strong relationships with favorable versus unfavorable outcome. Other studies again have looked more detail at glutamate. Excitotoxic glutamate increases. We know that's related to poor outcome and favorable outcome or mortality. And this quite nice paper coming out of UCLA where they define these metabolic crises. But what about statistics to reality? So we now see improvements in brain chemistry through a number of interventions. This is the LP ratio, the beneficial effect of hypertonic saline, the beneficial effect of a EVD, and the beneficial effect of decompressive craniectomy. But beyond that, we're beginning to learn more about thresholds for cerebral perfusion pressure. We know the Brain Trauma Foundation guidelines talk about a cerebral perfusion pressure of around 60 to 70 millimeters of mercury. This is a patient on our ITU, on inotropes, and the CPP is 100, way above that recommended by the guidelines. The inotropes are reduced, the CPP comes down, but the consequence of that is this massive increase in the lactate-pyruvate ratio from around 30 to approaching 70. This we know is harmful. What's interesting is that the CPP for this patient is outside that recommended by guidelines. So it may be that this technology can assist in defining individual ICP, CPP thresholds. The guidelines do not work for all. And there's been a number of different therapies that we employ in the intensive care unit. I'll come on to them, where we can look at the effects on brain monitoring. Can brain chemistry predict secondary deterioration? So this is a relatively small study, but it showed that patients with labile ICP had labile microdialysis levels, particularly the lactate-pyruvate ratio, but elevations in chemistry appeared to precede the majority of episodes of high ICP. And this is Tony Belly's work from Birmingham, again showing that a measurement of an abnormal lactate-pyruvate ratio when an ICP was normal carried a significant risk of that patient developing intracranial hypertension within the next 3 hours. So can microdialysis be actually incorporated into management algorithms? So there's been, again, some more consensus meetings. We ran one in Cambridge looking at a number of collaborators and a number of different facets of microdialysis. What the consensus statement stated was that the chemistry should be interpreted in the context of the clinical condition of the patient. I think it's really important to emphasize that all these monitors, they're adjuncts, but they're not the be all and end all, and you need to look at the monitors, what are all the monitoring is showing, but also how the patient is doing clinically. These techniques are focal, and clearly brain chemistry will vary in different regions of the brain. And in TBI, perilesional brain will demonstrate more perturbed chemistry, but you need to interpret the chemistry in the context of the catheter location. But what do we see? We see periods of low or even zero glucose. So we have patients where there is no glucose available to the brain, generally associated with an unfavorable outcome. There is a relationship between serum glucose and brain glucose, but that is not absolute. And then Tony Strong has done a lot of work on this spreading depolarization, where we can see very rapid reductions in brain glucose. A high lactate pyruvate ratio is associated with unfavorable outcome. As I said, it is a marker of cellular redox, and it is a quantitative measure. The advantage of a ratio is that we're not so concerned about recovery from the catheter because that is accounted for by the ratio. What is important is that it begins to give you a feel on differentiating between ischemia and hypoxia, and this concept of mitochondrial dysfunction when, despite adequate supply of a substrate, oxygen, glucose, etc., the cell is still failing because the mitochondria are not working properly. Glutamate, we're seeing some big increases during seizures. Measuring glutamate may be useful in estimating prognosis. Glycerol is released when cell membranes break down. They are less specific. It's a marker of cerebral injury, but I think when glycerol goes up, it is probably too late and cells are already dying. So what does the consensus statement say about placing these catheters? This applies to both microdialysis and brain tissue oxygen. In diffuse TBI, we recommend placing the catheter in the non-dominant frontal lobe. In focal TBI, clearly there are different options that depend on whether the goal is to monitor tissue at risk or normal brain, for example, to guide systemic glucose treatment. Where there is a focal lesion, we recommend, if feasible, the catheter is placed ipsilateral to the lesion, but not directly in the lesion. And of course, there is the option for multiple catheters. What do you do when you see the glucose low? This lower threshold of 0.2. So we now actively intervene in this situation, and we will give these patients dextrose to try and increase their brain cerebral microdialysis. When the lactate pyruvate ratio is high, we will act by increasing initially the cerebral perfusion pressure with inotropes, but there are other therapies, increasing the PaCO2 or increasing the oxygen delivered via the ventilator and correcting anemia. So these are some of the potential clinical applications of microdialysis in traumatic brain injury and in subarachnoid hemorrhage. We often see patients on the ICU with raised ICP. How much do we chase that? If the ICP is around 20 to 25, but the brain chemistry is stable, that is something that we may live with. It may help us titrate inotropes. We know when the chemistry is getting deranged, the ICP may become abnormal, so that's something to look out for. We all see patients with an ICP monitor. You stop the sedation, you try and wean them, the ICP goes up. The consequence of that is that people tend to put the patients back on sedation. Can you actually use this to assist in weaning, tolerate a higher ICP if the chemistry is stable? And as I said, I think this is becoming quite important, the monitoring and the treatment of low cerebral glucose. In subarachnoid hemorrhage, we've been using it to look for vasospasm, decision-making for the poor grade patient, monitoring during aneurysm surgery, and again in relation to the low cerebral glucose. This is quite a nice study that's come out of Sweden looking at this wake-up test. I don't know what your practice is in Dublin, but in Cambridge we tend to keep these patients asleep, I know in many centres they like a daily wake-up test. Is that safe? Well, it may be safe, and you can look at whether it's safe by seeing whether the wake-up test causes derangements in some of the chemistry or cerebral oxygen parameters. So again, this is a potential clinical indication. The problem with microdialysis is that the technology is cumbersome with these vial changes. We're getting the measurements hourly. That's the issue of global versus focal chemistry, and I think we do need more centres using it. We need to look at its application in children, and we need to refine the protocols. Of course, you can measure other things with microdialysis, cytokines, other amino acids, so it does generate a number of new research questions. But the reason I think that it's not percolated into clinical practice is the technology. These hourly vials changed, nurse time, bedside analyzer, and we really need, if we're going to get this technology into routine clinical use, is to refine it. This is some of the work that's come out of King's, looking at continuous microdialysis with a sensor that is at the bedside. And then we're developing this technology, mid-infrared spectroscopy, to measure chemistry without the vials at all. That is going to be shining infrared light through the fluid itself to give continuous chemistry monitoring. I think once we get these technologies improved, then it will help in terms of the clinical application. It does appear to be reliable and safe. There has been advances, and we know abnormal chemistry relates to abnormal outcome. And I think it does have potential in terms of integrating it into multimodal monitoring, but the technology does need to be improved. Recently, we've published looking at the dynamics in terms of metabolic dysfunction in a relatively large number of patients. And I think this has been quite illuminating in the way that we can refine the diagnosis of traumatic brain injury. How do we do that? Well, we can measure trends in brain chemistry derangement with time, but more importantly, we can begin to dissect out these derangements. Do the patients have low cerebral perfusion pressure, dysautoregulation, a high lactate pyruvate ratio with hypoxia and mitochondrial dysfunction, low glucose and low tissue oxygen? Some of the patients may have derangement in only one of these parameters, but in other more complex patients, it is difficult to dissect these out, and some of them may have multiple ongoing derangements occurring at the same time. So what we're trying to do is refine the diagnosis. This is just not high brain pressure. There are these neurometabolic states. We clearly have normal metabolism. This can occur derangements in the context of intracranial hypertension, oxygen delivery failure, neuroglycopenia, inadequate glucose, but also mitochondrial dysfunction. And what we're trying to do is label this for each patient on a daily basis. And using the monitoring, we can define the signatures of these abnormalities through the LP ratio, the pressure, the brain oxygen, and the glucose. To refine this diagnosis, again, is it intracranial hypertension? Is it a diffusion failure or oxygen delivery barrier, neuroglycopenia, or mitochondrial dysfunction? And there are different therapeutic options. We can control ICP through therapy that I'll come on to talk about. We can increase the CPP. We can increase oxygen delivery. We can address low glucose. And we can also begin to look at this concept of mitochondrial dysfunction. Mitochondrial dysfunction is thought to occur when all the other monitored parameters look normal, but brain function is failing. How can we do that? Well, as well as using microdialysis to recover and measure brain chemistry, we can actually interrogate the brain by labeling substrate, glucose, with a 13C label, giving it down the catheter, and then analyzing it using 13C spectroscopy. So we can label glucose. You can see how it is metabolized because you can pick up these different peaks of metabolite. Some of the glucose goes down this pentose phosphate pathway, but we can measure how much is going down glycolysis, how much is actually used in the TCA cycle, because we can look at some of the products of this cycle, particularly glutamate and glutamine. Mitochondrial dysfunction is probably occurring at the level of the electron transport chain between complex 1 and complex 2. And there is a theory that you can actually bypass and drive that with one of the intermediaries of the TCA cycle, that is succinate. So some of the studies that we've done very much in the research domain is actually to label succinate with a 13C label, give it down the microdialysis catheter, and see if we can pick up some of the metabolites. And if you do that, you can see that this succinate is actually used. It is labeling glutamine, and also it appears to have a beneficial effect on the lactate pyruvate ratio. So a number of examples now where this may be a therapy for mitochondrial dysfunction. Clearly, its early stages and more needs to be done. So how do we put all this together? This is the current algorithm that we use for the management of patients on the intensive care unit. In Cambridge, I'm sure you have something similar, but we have our gold standard of an ICP of less than 25, a CPP greater than 60, a brain tissue oxygen target of greater than 15, and a lactate pyruvate ratio of less than 25. This is achieved through these 5 stages of therapy. We tend to sedate with propofol. Muscle relaxation with atracurium is routine, and we use fentanyl as an analgesic. We nurse the patient's head up. We have careful control of the arterial carbon dioxide down to about 4.5 at stage 1, avoiding hypoxia, normothermia. Stage 2, we're quite aggressive now in terms of the use of external ventricular drains to try and control ICP, even when the ventricles are relatively small. Stage 3 is the use of inotropes to augment blood pressure, hypertonic saline or mannitol, further hyperventilation to control ICP. Again, we used brain tissue oxygen to monitor that. Hypothermia, we still believe, has a place despite some of the recent evidence. It does appear to be good at controlling ICP, but you need to look at the side effects, particularly infection, respiratory problems. And then, of course, there are a number of patients who have ongoing issues with their ICP, and in these are the options for thiopentome, decompressive craniectomy. We've tended to move away from barbiturates. They're rarely used now, and at this stage we would go for a decompressive craniectomy. But can we try and refine this protocol in a stepwise fashion? So we start with the ICP. So this is intracranial hypertension. If that is greater than 20, it will trigger that protocol. We will look at the brain tissue oxygen. If that is less than 15 millimeters of mercury, we will try and increase it by increasing the CPP by around 10 to 20 millimeters of mercury. And of course, that works when the patient is autoregulating. If it's still low, there is the option to increase the FiO2 through the ventilator by 20% up to a maximum of 80%. If we're still not winning, we look at the brain glucose, less than 1, neuroglycopenia. We will increase the plasma glucose to 7 to 10 millimoles per litre using 50% dextrose. So this is higher than we would conventionally do. If these other parameters are now normalized, but the lactate pyruvate ratio remains high, we would call that mitochondrial dysfunction. And one potential therapy, again experimental at this stage, is to give succinate. So just turning back to this algorithm, I just wanted to draw out 2 further points from this. The first is that there are, as you know, trials of some of these interventions. So there is currently a randomized trial of hypertonic saline versus mannitol, the SOS trial. There have been a number of trials of hypothermia, which have shown harm potentially due to hypothermia, so that would need to be used with caution. And decompressive craniectomy, as I said, following rescue ICP, we've tended to move towards that and away from barbiturates. But the other important point about this is that although this is an intensive care unit-driven algorithm, depending predominantly on the gold standard of ICP, 2 of these interventions are surgical, so the EVD and decompressive craniectomy. So the patients who go through this algorithm with an ICP sensor need to have access to surgical care, and that may need to be delivered promptly. So we've had requests from other parts of the region to ICP monitor patients if we were unable to admit them, but we feel very strongly that these patients need to be managed in a centre with both neurosurgical and neurointensive care expertise. So if we go back to the consensus statements, I think the take-home message is ICP is gold standard, and ICP and CPP monitoring as part of a protocol-driven care in patients at risk of elevated ICP. I think that's a given. Monitoring brain tissue oxygen in patients with or at risk of cerebral ischemia or hypoxia is best done through brain tissue oxygen sensors. And cerebral microdialysis has potential in patients with or at risk of cerebral ischemia, hypoxia, energy failure, and particularly glucose deprivation. So to conclude, I mean, how can you take this forward? I think if people are trying to go beyond standard ICP monitoring, probably the first step is to look at some form of autoregulation directed therapy. This is relatively simple to introduce. You don't need any further sensor other than ICP using the ICM Plus software. And as I said, when the patient is autoregulating, our practice to try and increase the blood pressure to reduce ICP can be very, very effective. The second monitor, which I think is clinically appropriate in many patients now, is brain tissue oxygen, both in terms of looking at oxygen delivery, but titrating hyperventilation to control ICP. Microdialysis is very much the third monitor. The LP ratio is important prognostically, but I think until the technology is refined, this will remain predominantly a research monitor. So I think the order is very clearly ICP, brain tissue oxygen, and microdialysis. Just like to thank many of my colleagues in Cambridge through the ABI group. Many of these were PhD students who undertook a lot of these studies. They've now become consultants, and a special mention to Kerry Carpenter, our neurochemist. She's been very much involved in the design of the studies, particularly the 13C work. Thank you very much for the invitation. We are hosting the International Neurotrauma Society meeting in Cambridge in 2024, and you'd be very welcome to join us for that. But thanks again for the invitation to come and talk to you today. I'm happy to answer questions. Karen.
There's one thing I'm confused about, and maybe I have it wrong, but are you advocating, do you actually put them in EVDs before starting inotropic management?
Yeah, that's a good point. So stage 2 and 3 are pretty much in parallel. But no, you're right. Although it's 5 stages, there clearly is overlap, and you know there are many patients. Hypertonic saline seems to be used more and more and earlier and earlier.
Bring them down to put in the EVD.
But I mean, the EVDs, I don't know how much you use them, but even with patients who've got quite small ventricles, it does seem to be effective. I think a lot of these patients are at the cusp of the pressure volume curve, and even draining a few mils of CSF can suddenly drop the ICP quite dramatically. And in about 50% of the patients, that's sustained.
We are using EVDs for the image guidance.
Yeah, we use the image guidance, yeah. Yeah, I think in fairness that the stage 2 and the stage 3 are very much in. It's partly because there was some reluctance to put in EVD, so I think having it at that stage 2 just does make people think more. Of course, in the US, it's standard practice. They don't tend to use these parenchymal sensors in many places. They go for an EVD straight off as the measurement device, and then also use it for drainage. Yeah.
We used to do that.
We used to have the combined ICP monitor and EVD.
Yeah.
I don't know why they fell out.
I don't know either, because they were, but people don't tend to use them anymore.
Just the one line. Thanks very much.
Yeah.
Was decision making incorporates a rapid.
Yeah, I think what people are finding is that the particularly a rise in glutamate and particularly big rises in glycerol are generally felt to be quite devastating. But having said that, you need to look at these monitors in the context of the clinical condition of the patient, the imaging clearly. So I think it's just another marker towards guiding prognosis.
And are your patients with poor-grade subarachnoid automatically getting a bolt?
No, so that's waxed and waned a bit. Right. The TBI, it's become routine, but the poor-grade subarachnoid is still very much what I would call research.
So it's not sort of both that would managing the patient.
No. I think it's more information. But as I said, big rises in glutamate, big rises in glycerol tend to be associated with a much poorer prognosis.
Regarding the brain tissue oxygenation, should we be awaiting the results of the Bonanza trial before we?
Yeah. I mean, if you believe in phase 3 RCTs as the evidence, I think that's a reasonable approach. But we've grown up with it, and personally, I think it is very, very useful, particularly in terms of this hyperventilation business and the delivery of oxygen. So we will increase the CPP to get more oxygen through.
So we are at a stage where we are not using it.
Yeah.
Should we join the trials, or should we just start using it as the guideline?
I don't know whether, did you get approached by the Bonanza?
Yeah, we will. We're on the road to joining Bonanza. We kind of do a torturous process thing and actually get it and get funding. We will probably join.
I mean, I think the answer to the question, I don't think you should start. Starting doing it as part of an RCT is the perfect way to start doing it, isn't it? So that would be the way forward, I would have thought. Yeah.
Yeah, thank you for that. Absolutely fantastic talk. And I was going to ask you a question as well. I don't think your unit, because probably don't have equipoise on brain tissue oxygen monitoring, you think it works, and that you probably wouldn't participate in that. And I see your ICP level of 25, and the Center TBI study, one of their papers talks about the dose of ICP, so the duration of time spent at a higher level, and it being a bad thing, at least certainly associated with poor outcomes. Do you have any?
Yeah, so I mean, clearly there are views on dose, but you've got to try and make it simple and practical for use, which is why I guess we have these strict thresholds. So I mean, clearly you can look at dose, and the ICM Plus software is quite good at looking at dose. But there was a lot of discussion about this number of 25 and 20. And as you know, the DECRA trial had an ICP threshold of 20, and for rescue ICP, we went for 25. If you look at the data, the 25 seems to be this big threshold difference between mortality and survival. So for me, 25 is about right. And then the crazy Brain Trauma Foundation guidelines said the threshold should be 22. So I said to them, well, should it be 21 and a half? But, these are numbers, but we have to try and be sensible and apply a sensible approach to them. They're guidelines.
Thanks, that was fantastic. Just a quick question. Do you look at the ICP, just the numbers, values, or do you look at the waveforms?
So that, again, is a very good, in terms of research projects, the waveforms, but generally in clinical use, we look at the number. Yeah. I mean, the other point, it's an important point that's reminded me. So the waveform and the way the PRX index is calculated through the relationship with the blood pressure the waveform's important because the skull needs to be intact. So what people don't realize is that PRX and autoregulation, that algorithm requires the skull to be intact. If you undertake a decompressive craniectomy and the waveform is very flat, as you know, then you probably can't calculate the status of autoregulation. Yeah, that's a good point.
What the analysis we got, the microdialysis, gives you a global reading, doesn't give you a global.
Correct.
Exactly what happened. I see it used in guidelines. How do you
No, it doesn't, and that's why the consensus statement looked at catheter location is important. But if you've got a patient with a cerebral contusion that may not be prognosis defining, having the catheters in the normal brain, which is our first step, if you're protecting the normal brain, then you're probably doing the right thing for the majority of the brain. What I think we worry about is if the catheters in a contusion, then we don't quite understand what we're measuring. So, but as I said, catheter location is really, really important. But I think ICP is not uniform either. I think there are ICP gradients. We assume it is, but certainly you see differences on each side of the folks. So I think even ICP is probably not global. Yeah.
On the catheter location, when you say in the normal brain, that's for microdialysis or microdialysis and oxygen.
So microdialysis, I think you can put microdialysis and oxygen in the same category in terms of the location. For diffuse injury, we go for non-dominant frontal lobe, and that's most of them. Contusional injury, as I said, I think putting it in the contusion is probably not the right thing to do, because you could apply therapy that could be harmful to the other brain, to the remaining normal brain.
Do you do ICP monitoring after decompressive craniectomy?
So we do, and again, that's a really good question, and many people don't. In rescue ICP, we did because it was part of the protocol, and there were about 9% of the patients had intracranial hypertension despite the craniectomy, and they actually went on to get barbiturates. So we do it. I think you need to look at a sense of caution in terms of how to interpret it. Did you do it?
I don't leave it in for 2 or 3 days.
Yeah.
And just look to see if there's a trend.
Yeah.
Before deciding to wake it up, and obviously just feeling it.
Yeah.
I don't, because I don't know how reliable it is.
Yeah.
I think you've got a decompressed craniectomy with pressure still going up.
And when the ones that when rescue ICP that have failed a decompression and then went on to barbiturate coma, that was a very bad thing. Yeah, I think once you get to that stage, you know.
I have a question about anemia.
Yeah.
Do you treat that more aggressively with your oxygenation monitor?
So if the brain oxygen is low, then we would look at different thresholds. But I think it is quite controversial. The amount of the intensivist probably know more is what the hemoglobin level to run these patients at. But I think if they do have a lower brain tissue oxygen, then for me it makes sense to try and run them at a higher hemoglobin. Well, I don't know what thresholds do you run at?
Find you're transfusing more patients.
I don't think it's made a huge amount of difference.
Yeah, you will transfuse more because the threshold is there. I don't think that there isn't big enough study that higher or lower health. If you're a believer that is a bad thing. And it's a balance of this. I think in general we target higher hemoglobins without too much evidence.
I think this is where this concept of mitochondrial dysfunction is quite helpful, because whatever you do in terms of improved delivery of whatever, you're still not going to win if the mitochondria aren't firing. And I think to try and get that as part of the diagnosis is helpful. Yeah. It's you know, you remember learning all that stuff in the biochemistry, and I thought, this is rubbish. I will never ever need to know this again.
My daughter's been coming home. And
Yeah.
You never need to know this.
I know.
I'm going to go home.
Yeah.
But I thought,
Ultimate insight from
I mean, you know, we very crudely look at outcome classically by the Glasgow outcome score, and that's for me quite an insensitive, crude measure. But I think we do need to be doing more in terms of quality of life, and particularly like neuropsychological and quality of life outcomes. But I don't think we've got to the stage of the monitoring actually defining that. I mean, what we're trying to also move away is these terms favourable and unfavourable, because we saw that in the craniectomy trials. that what's favourable for one family is not favourable for another, and some people will accept a high degree of disability, whereas others clearly won't. So I think you're right, we do need to get much better at these outcome measures. Yeah.
Thanks so much, Peter. It was a fantastic talk, and congratulations on your giving Ireland citizenship. That's great news. In terms of the microdialysate, I think it's an amazing technology advance there. Actually, spectroscopy and the work that's going on in pigs. And we will mention, of course, for neuroglycopenia as part of that setup. How far away do you think we are from biotechnology?
Yeah.
Triple goals, if you like.
Yeah. So I mean, we've got a study going on at the moment where the dialysis runs continuously, and we can measure glucose lactate per ratio through the spectroscopy, so you don't actually have to collect the fluid, which I think will be the next step. But for microdialysis to fly, for me, you need to stick a probe in the brain with some sort of sensor that tells you what the glucose is and the LP ratio on the screen, like the ICP and the brain oxygen. I think that's the only way that this is really going to get outside academic centres. It's too cumbersome at the moment. So whether you can have some sensor that measures the glucose directly in the brain, lactate per ratio directly in the brain, I'm sure that's going to have to be the way forward for this. But I think that's a while away.
Last question. Your centre did more to demonstrate the dangers of hyperventilation.
Yeah.
And they study looking at
The PET studies, yeah.
Looking at ischemia, especially around and just wondering, how do you do it when you've got your brain tissue oxygen model in a really not quite sure
How do you do it? Well, I think you have to, there's a margin of error and a margin of tolerance. So the PET studies, I mean, the Coles PET studies, we were hyperventilating down to 3.5 kilopascals, which I think was extreme. But I think there's a margin of error. So we would perhaps go down to 4 now, but that's quite unusual. But we would look at the brain tissue oxygen. Now, I take what you're saying, that it may be all right in the normal brain, but the vulnerable brain around a lesion could be at risk. But I think that's why you need probably a margin of 0.3, 0.4 kilopascals. Yeah. And then I think if that's the case, then maybe this is where perhaps an EVD or hypertonic saline, where you should perhaps look at other therapies rather than just the hyperventilation.
worry about the rebound then as well.
You do. Yeah. It's a temporizing measure. Yeah, exactly.
A bit of failure or the keep you here all night.
No, it's all good.
It's all been really, really fantastic.
No.
Professor Donnacha O'Brien's going to
bless them.
present a tiny little gift as a thank you.
Do you know we did the exam together in Nottingham?
Yeah.
It's
We've always had cordial relations between our friends in England and friends in Ireland, despite numerous political differences. So we've always taken your lead, and thanks very much.
Oh, thank you so much.
Thank you very
No,
much.
not at all. Thank you.
Fantastic. Fantastic.